My name is Brian Dow. I'm the Deputy Chief Executive of Rethink Mental Illness, and I'm here with my colleague Mark Yates, so you get two for the price of one. We're going to divide this presentation into two parts, despite the fact we've had a sort of massive drive to become the one Rethink, so we're going to be two halves of the one Rethink today. I'm actually going to start with a bit of audience participation, if that's okay with folks. You've all had your lunch, what a lovely lunch it was, so I'm going to get you to do a bit of movement by asking you a very simple question. Well, I think it's simple. I want you to imagine one of two prospects, if you can. The first is that you are diagnosed with a mental health condition. Just imagine going along to your GP and your GP tells you that. And there may be people in here who have. And then the second scenario I want you to imagine is that you become homeless. So having thought about that, I want you to stand up if you think the first scenario is the most frightening of those two. And I'd like you to stand up if you think the second scenario is the most frightening of those two. Right, well, that's my presentation complete. Thank you very much. I have to say, I did not quite expect that response. And hopefully that means I'm speaking to a good audience, because actually what we're here to talk to you about today is just how central housing, good housing, and particularly supported housing is in the recovery of people with even chronic and severe mental health problems. So I feel like you're on my side from the start, and that's a nice place to be. So if you don't know who we are, we're a leading charity provider of mental health services. In fact, we're one of the largest in England. And we're also a leading campaigning organisation. And that makes us, I always say this, and it's a dreadful phrase, relatively unique. You're either unique or you're not unique, but we are relatively unusual, perhaps, in that, if you like, we're doing direct work with people locally in services, and those services take a range of different forms. Today we're going to concentrate on housing, but actually also we're talking, if you like, to the system and to decision makers very senior up the chain, and including meetings with the most senior folks in the Department of Health, for example, and NHS England, and at a time when mental health has become arguably one of the most prominent issues in terms of health. That's a conversation which I think is beginning to eventually bear fruit. And no doubt there's lots of people in this audience who've been doing a version of that for a long time. So we support tens of thousands of people each year through our groups. We were actually born as a support group network, so essentially a group of families whose grown-up children had schizophrenia, felt they had nowhere to turn to. The medical profession weren't supporting them. They felt that their family were stigmatised and frankly felt scared. So they came together as the National Schizophrenia Fellowship to exchange support and information to each other. Now obviously in the age of the internet and Facebook and so on, the way that we provide information is very different. But those groups still exist to this day, and we have about 150 of those across England. But we also, as I said, are a very large provider of services, and Mark will tell you a little bit more about that. And we run the Rethink Advice and Information Service, which is open to any member of the public who's concerned about either themselves or a loved one who has a severe mental illness. So all the work that we do, though, and any campaigns that we run, I try to describe this as a sort of virtuous circle. So we run services, and the experience of people in those services form the bedrock of our campaigns. And we campaign to ultimately make the public and the political classes care about mental health, to invest in it, to develop policies so that actually services are possible to run, and the experiences of people in the services form the bedrock. In other words, it's a constant virtuous circle for us. The experience of people in our services, in our groups, who are coming through to our information line are the campaigns that we run. And in terms of the ones that we've run recently, I guess we could say that supported housing is one of the most important. So I don't know if that was absolutely unanimous, but I think more or less all of you in the audience seem to acknowledge that having a safe, supportive and comfortable home is critical to your health, both your physical health and your mental health. And the reality is that in terms of mental illness, that has been a system that's been under a degree of attack and a degree of threat over the last few years, and we've been working hard to try to shore that up. So housing is fundamental to everything that we want to achieve. The government in the 5-year forward review have put it like this, that there can be no parity of esteem, whatever that happens to mean, and I think there's a growing debate about that. but without safe and secure housing. And that's important, not just, I guess, from a moral perspective, but also from an economic and assistance perspective. 39% of delayed discharges from mental health trusts are due to a lack of appropriate housing. That's from the CRISP Commission. I mean, that's an extraordinary. If you think about where we're constantly having debates about the size of the envelope, how much money should we put into the health system, but the notion that there's an enormous amount of money, and we are talking about an enormous amount of money that's stuck up there in delayed discharges that could be released down through the system to get better outcomes, that's a lose-lose-lose scenario. So we've got to change that. Housing is also imperative both to, if you like, prevention, but also treatment in the community. So there's a growing body of evidence, although I'll talk a bit more about that in a second, that housing is key to improving outcomes for patients and the NHS. It's a key challenge for the NHS. Without good local provision of housing, then you're going to get more out-of-area placements, something that the system is trying to reduce, and you'll also in the end get repeat admissions. So again, it makes no economic sense. And the most expensive forms of supported housing are actually far cheaper than a hospital bed. I think the stats are something like it can cost up to £2,000 a month for supportive housing for a month. But a bed in an acute hospital costs more than £13,000. So it's nearly 7 times more expensive to have somebody in that ward. That does not make any kind of sense. So the 5-year forward review was a really important turning point in beginning to change that whole debate, and it seems to be a debate that all of you have woken up to. Not that I was suggesting you were asleep, either after lunch or before lunch. But so, specifically, what does the 5-year forward review recommend? So firstly, it's the right level of protection should be in place for people in need of mental health supported housing. So that was one of 2 key recommendations. So when the 5-year forward review published the funding reforms to supporting housing, those were proposed, they would have had limited support in supported housing roles helping patients in the NHS. So we were concerned and have been concerned for a number of years that when it comes to supported housing, actually the public don't particularly get it. It's quite a difficult thing to explain. And of course, there's always an argument that if the public don't understand an issue and there's not a mandate for it, then politicians are more likely to walk away. And I hope we don't have any politicians in the room because I'm about to speak fairly frankly. We felt that the reforms that were being proposed to supported housing completely undermined, on the one hand, all of the positive developments that we were seeing on the other. So, you know, how could you talk about parity of esteem? How could you talk about trying to put money into the system? How could you even begin to think about what you're doing to support children and young people if the lifeline that people require when they're at their most ill is simply not there? So, those proposals to supported housing, particularly to cap the housing benefit payments, were something that we fought fairly vociferously. And I have to say, I do remember having debates within Rethink and talking about, you know, what's our chances of success in this. We know the direction of travel for the DWP. We know there's years of austerity have meant that there's a kind of real kind of screw down on costs. And for us, actually, it was an important point of principle, not just to do the right thing, but to be seen to do the right thing. And again and again and again, when we surveyed our members or people who were using our services, this was something that came through as the most important thing to them, just as it seems to be to you. So, 2 years of dogged campaigning, and I have to say, although it was led by us, the reason it was such a success is it was a coalition of many other interested parties, not just on, if you like, the mental health component of supported housing, but supported housing more generally. People, as you know, people with mental health problems are only one group who are supported by supported housing. So they will continue, I'm pleased to say, to be funded through the welfare system. So that was the first recommendation. But the second recommendation was that the government should build an evidence base for mental health supported housing. And that's really important because in that classic view of the world, what gets measured gets done. We've been doing something similar in terms of co-production, a phrase I'm sure that you're all familiar with, although again there's an awful lot of debate about what that actually is in practice. But the evidence on it is relatively anecdotal, and it's pretty hard to persuade commissioners, and it's pretty hard to persuade trusts and so on, to get involved with co-production if the evidence isn't there. Now, we've seen from the work that we've done that the difference it makes in terms of actual clinical outcomes, as well as saving costs, is there, but we need to build the evidence. And it's the same thing here. It's about building an evidence base for mental health supported housing. How does it actually save costs? How does it actually support people? What are those outcomes, and how do we measure them longitudinally? So, I think it's fair to say that housing providers have been concerned by the lack of progress on that. I don't know whether or not we have any housing providers in the room now, but I think we'd love to work with you to help to generate that evidence. And I think at the same level we're seeing actually some innovative practice at a CCG level. There's one or two places where I'm aware that they're putting mental health nurses in supported housing, so that's kind of moving the care upstream. And I think, again, a lot of evidence that that's something that the system is thinking about, not just in supported housing, but in primary care. How do we make sure we're avoiding the flow through of people into crisis, and how do we make sure that we're supporting people when they come back down out of crisis? And the reality is, if the supported housing isn't there, then you'll have more people going up and more people getting stuck. And that's, as I said earlier on, that's a lose-lose. So we need to build that evidence case. We need to work with people such as yourselves to do that. And we think it's a vital pillar in the integration of the 5-year forward review. So what comes next? There's currently a 35,000 by the nearest estimates, and I think it's the National Housing Federation, have estimated there's 35,000 there's a 35,000 shortfall in supported housing places, or there will be by 2021. And that's potentially catastrophic in the context of the direction of travel. It's unclear how much of this is made up at the minute, but there are continued issues, as I mentioned earlier, on without varied placements, with delayed discharge and with repeated admissions, and we need to try to tackle that. Our research shows that about half of inpatients who wanted supported housing were actually offered it on discharge, and that's a heck of a big gap, and I don't think that would be acceptable for other forms of physical illness. But we're also in a key moment in the NHS, so we have the development of a 10-year plan, and I think it's really a chance to put those arguments. There's obviously a big debate going on at the minute about whose money that extra investment is, and NHS England takes a clear view that it is its. But obviously one of the things that we're trying to persuade senior decision makers is if that money is prevented from getting through to local authorities and others who are involved in supported housing, the net effect on you will be you're not able to deliver the outcomes you want to be. So actually beginning to see a lot more in the way of integration and pathways, I think is part of the objective here. So I've talked for a little bit, and before I hand over to Mark, I just wanted to kind of show you what this means for somebody who's actually affected by these issues.
Hi, my name's Molly Jo Lynch. I'm reading from my phone bullet points because my memory is terrible, and I want this to go smoothly. So yeah, I'm Molly, I'm 22. When I was 17, I was in hospital. I was diagnosed with schizophrenia. I moved into Rethink, St Andrew's Court, in August 2014 at the age of 19. I came to Rethink straight from multiple very long hospital admissions. Rethink gave me a chance to live outside of hospital. I still receive outreach support. My link workers, they help me understand letters I receive about benefits and general things, because I sometimes find things hard to understand, and what action I need to take, what appropriate action when I receive these letters. I've been volunteering since a couple of years ago. I've been volunteering at a day centre for adults with learning disabilities, which I absolutely love. And actually, I've just, in the recent weeks, applied for a paid job there part-time. To be blunt, I wouldn't be where I am now without Rethink. I don't know if I'd even be around. I can't fault Rethink.
And you know what I want to say about that story is that it doesn't really matter to me, and I know it won't matter to Mark, that whether it's Rethink or it's another provider, her life, as she said herself, would have been lost. And I have colleagues like her who've been in secure care. They've been stuck there not just because of the quality of care in secure care, but because there's nowhere for them to go to. And I think that's completely unacceptable. So if we don't invest in supported housing and make it happen, whatever the barriers are, you'll get more lives lost like Molly's could have been. So, Mark, over to you.
Yeah, hi everyone. My name's Mark Yates. I'm Director of Operations at Rethink. First of all, I think Molly makes the case for supported housing better than I could, standing here talking to you a little bit about what Rethink does. But I am going to do just that. So I'm going to... That's Molly again. I am going to talk to you a little bit around our accommodation offer. So we deliver a wide range of supported accommodation services across the mental health pathway. They range from what we term as crisis and recovery houses, so services which either stop people from having to go into hospital when they're in a crisis, or support them in stepping down from hospital during or kind of towards the end of a crisis, and they're staffed 24/7. They're CQC registered services that provide intensive support to people during that time, and they tend to be quite short term in their nature. So supporting people to recover and leave the service and back out into the community. We deliver high support or enhanced recovery services, and again, these services tend to be CQC registered, and these are for services that perhaps provide a longer term period of support for people affected by severe mental illness. Often they can require a degree of personal care. We run a number of registered care homes, registered nursing homes, that support people with nursing needs and employ registered nurses into those. We then have a range of supported housing services which support people with high, medium, low support needs, where the focus is very much on supporting people on a pathway through to independent living or through to as much independent living as is possible. Intensive housing management services, where we give people a tenancy, but perhaps provide some low-level housing management support to help people to maintain those tenancies and maintain their accommodation. And as Molly referred to in her presentation, a range of floating support and outreach. So we try and retain connections with people when they move through and out of our services, to ensure that they're kind of leaving with the skills that we supported them to develop and maintaining those over a period of time. So what's our approach to delivering support? And I think any kind of supported housing provider or care and support provider worth their salt would probably stand up and say the things that I'm going to say to you now, in terms of how we approach service delivery. In the fact that it is very personalised, we do look to be flexible, we do look to engage people in the decisions which are going to affect their lives. But that's very much driven by our goal, which is a better life for everyone affected by severe mental illness. So when we're working with individuals in our services, that's what underpins our work, trying to support them to live and lead a better life. We like to think, and some of the kind of better services we run because, you know, we know the reality of the situation. There are services that aren't as good as others, and there are our exemplars. The ones which work best are the ones where we have that real close integration with partner agencies. And I was heartened this morning to hear Tim Kendall reference on a number of occasions in his presentation our work at the Sheffield Crisis House, which is an example of a service which is very, very closely integrated with the Partnership Trust. Has a very clear kind of wraparound support from the Partnership Trust. We focus on where our skills and expertise are in supporting people to stay safe and well in a community-based setting, and the clinical support is provided by the Trust. And it's where those kind of services have evolved and developed in partnership with local agencies that we deliver the best outcomes for people. We support people to access and maintain long-term accommodation, support them with their daily living skills, in accessing education, training and employment. And we have a kind of varied approach to support, if you like. So we do a lot of one-to-one support, but we also do a lot of group work. So we support people in groups around specific topics or issues which may commonly affect people who need housing-related support. And there'll be a little bit more on peer support in the video, which we're going to show you in a short while. We're increasingly focused on the physical health needs. So again, this morning there's a bit of a theme around looking out for the kind of physical health needs and the mental health needs of an individual, and we're trying to focus our support more around the physical health needs as well as the mental health needs of anyone who needs to access our services. We have strong involvement, so we try and get people involved as much as we can in decisions around their services, and provide volunteering opportunities, which often result in people volunteering within or around the service that they've received from Rethink. And we also support people to maintain their properties and tenancies, so when they move on from our services, they're able to kind of develop those skills and maintain their own accommodation. I think one of the advantages that we see as an organisation, and Brian talked a little bit earlier on about kind of One Rethink, is the wider offer that we can generate through the work that we do. So as well as the direct service delivery, there's a kind of wraparound support, if you like, that we're able to provide to people who access our services. So we run a number of helplines, but two in particular. We run an advice and information service, which people can access a range of resources from to support them with understanding perhaps the mental health system or getting advice and information about their particular condition. And we also run a money advice and mental health service, which is the first of its kind in this country, which is really supporting people with money issues and mental health, and that's a service that we run in partnership with Mental Health UK, and has been funded through a partnership that we've developed with Lloyds Banking Group. We run a number of specialist groups, and again, Brian talked earlier on about the way the organisation was founded back in the 70s through a carers group essentially, and those groups meet now. We have 130 registered groups which run across the country. They can focus on anything from support for siblings, support for carers, focus on a particular interest around music or the arts. They are very much kind of led by groups and people with lived experience of mental illness who want to come together and lead a group of people in certain activity. Already talked about our work on Move On and outreach, but equally wanted to talk to you about our campaigns and policy influencing work. And again, as Brian articulated earlier on, what we are able to do as a service provider is understand the experiences of people living in our services, the challenges that we may be facing as a provider with a local commissioning landscape or local issues in terms of closures to services, and try and feed that through our internal systems to make sure that we're sharing those messages within the system at the right parts, whether or not that's with policymakers or people who can make decisions around these types of matters. And the final point is around the specialist fundraising that we do. So we've had some success in recent years around developing specific fundraising approaches for our services. So as well as delivering the services that we're commissioned to deliver, we will look for people who are willing to fundraise fund additional support in services. So we have examples in our North East Prisons service, for example, where we have specialist female support workers who have been funded by a trust fund with an interest in supporting females, and we've been able to access that funding through the work of our fundraising team. I just wanted, before we play our next film, just share a little bit kind of a provider's perspective on the commissioning landscape. I think the first thing that I did want to say on that is that we know it's not easy as a provider. We've been involved in many conversations with local authorities and commissioners around the impacts of funding cuts, and we know that there's not an endless pot of money out there in the system that we can access. So I think the first thing that I wanted to say is that we know it's a difficult climate and a difficult landscape, if you like. But within that, we do see as a provider things that perhaps could be done differently, which would perhaps have a different outcome or a wider benefit. One of the things that we do kind of struggle with as a provider is perhaps inconsistency in approaches to commissioning. So in one area we may see a certain type of service being closed because there's conversations around its relevance or its value or the impact it's having, and in a neighbouring borough we may see exactly the same service being commissioned as a bright shiny new idea, and there's probably something in between that which is the truth. But I think as a provider, kind of navigating that landscape can be quite tricky, and the fact that perhaps there isn't kind of the whole system's kind of learning going on can be difficult to understand. I've talked a little bit about us understanding that the funding and budget pressures, and we do know they are there. But I think there is sometimes a sense of frustration on the part of providers that there isn't quite that integrated, joined up thinking that we think would help kind of generate those better outcomes and impact both on the system and on individuals. And I do think sometimes we are quite uniquely positioned to be able to kind of understand the wider landscape. We may provide a social care local authority funded service that's supporting people to step down from hospital, and a cut to that service may impact on that part of the pathway, and sometimes we feel that we're struggling to kind of make that kind of conversation heard and understood in a local environment. And I think that we can play a role, and we want to play a role in influencing and supporting some of those decisions. I was interested in Liz's presentation this morning from Health Education England about the ambitions around the workforce and recruitment and retention of the workforce. I think that there's almost kind of a hidden factor here, is that the uncertainty, particularly around providers in the third sector like we are, the impact on commissioning and of commissioning decisions, I think has a dramatic impact on our workforce. And I know Lizzie talked a lot about wanting to engage the third sector in conversations about workforce, and she and health education are keen to understand how they can better support the workforce. I think one of the issues and challenges that we see is the commissioning kind of landscape does impact on us. So the lack of clarity around the future of services, the very short time frames in which services are commissioned, the very kind of last-minute decisions perhaps around retendering or recontracts, creates significant uncertainty for the people involved in the direct delivery of those services. And that can be difficult. We all need a degree of job security in what we do. And I think that does provide some leakage in terms of the good people who are working in our services, who want that certainty, who need that surety around their work and around their role. A lack of suitable accommodation remains a challenge. So we know generally in England that there is a lack of accommodation anyway. When you play that into looking to move people on from mental health supported accommodation, that can be even more difficult. So there is still a stigma associated with mental illness. There is a perception sometimes of landlords' unwillingness to take people with mental health issues, particularly if those issues have resulted in perhaps occasions of behaviour that's caused challenges in the past. And that's a particular issue that we do face in our services, is trying to support people who we believe are ready to move on to independent living into the right properties. And of course, there's a continued drive around, in all of that context, around personalisation and whole person care and support. So despite that landscape, we want to be more flexible, we want to be more person-centred, and we want to meet people's needs in a way which is meaningful and impactful to them. Our next video is a story that we've kind of published this week in line with Schizophrenia Week. And it's a story about a young guy named Luke. And Luke didn't access one of our supported housing services, but he accessed one of our groups that we deliver in Dorset. And yeah, we just wanted to share this short video with you before closing our section.
I remember just walking through the corridor at school and just noise. You know how like a train brake just kind of screeches, that kind of metal on metal noise? It was like that, but it felt like it was just echoing around the corridor. And it was empty, it was just me there. It was terrifying. It was something completely out of my control. With my psychosis, it started small, from those noises to words, just like hearing my name in a crowd. And till eventually it became to full sentences and talking to me. It was every negative thought about yourself given its own personality. By not allowing people to see it, I had ownership of it, which isn't true at all. I had no ownership of it. If anything, it only had ownership of me. I'd say the closest it really ever came to a crescendo was when I went missing.
We kind of split up. We all went off in different cars and different routes to see if we could find him, and then realised he wasn't there. So that's when I thought I might not see him again.
My next real memory is waking up with someone on Westcliff and not knowing what had happened. the pretense had kind of at that point fallen away, and probably for the first time had spoken to mum and dad about what I was going through. And I was put in contact with a care coordinator who honestly was my first real steps at communicating. But she also suggested going to a peer group which was run by Rethink. And it was a peer group to support those who had suffered symptoms of psychosis. And I dragged my feet to begin with. I had the feeling it was going to be very intensive, have to discuss what you were going through, but it couldn't have been further from what it was. It really was a very happy, positive environment.
We think in the early intervention was key.
I still consider it a real cornerstone of my recovery. I feel being able to get in early when it comes to your own mental health, being able to have those support networks and those conversations, being able to kind of shine light there and allow that progressive recovery to start. Well, I don't think that can be emphasised enough on how important it is. You'll be at your strongest when you're relying on other people, and the support from other people is invaluable. It will help your recovery, it will help you reach that level beyond that. You will get through this, and with the people around you who care and support with you, that just makes that journey so much easier.
Okay, and that was Luke again. Okay, so first of all, thanks to Luke and his dad for sharing that story. Just a kind of question that I don't have the answer to, and I'm not planning on giving the answer to, but just something to leave hanging there is what we have there is an example of a pretty low-cost, community-based early intervention service, which Luke described as the cornerstone of his recovery. And I just wonder what the alternative cost of Luke's pathway, if you like, could have been, both in terms of the price, how much would it have cost the system, but in terms of kind of the individual. So what would his recovery journey have looked like without that service? As I say, don't know the answer, but it's something that's just worth kind of leaving hanging there. So I was just going to finish with just a couple of perceptions around perhaps challenges and opportunities, and then perhaps have 5 minutes if we've got any kind of discussion points or questions that people wanted to raise. So clearly, supported housing has a role to play in the delivery of the 5-year forward view, and indeed in terms of the delivery of any longer-term mental health strategy. Again, question, challenge, how can we support people with severe mental illness to live happy and healthy lives without the appropriate safe housing and support? And I think, as Brian said at the start, there's a unanimous sense in the room that housing is a key kind of cog in that wheel. There definitely needs to be better connectivity between health and social care. We've talked and heard a little bit this morning about STPs and accountable care systems. I think there's some movement there, but actually in reality, when decisions are made, are they properly aligned? Commission and procurement decisions taken alongside one another? Is the wider impact of any decisions really understood across the whole system? Certainly from where we sit, we see some good examples of it, perhaps not as widely fleshed out in the system as we would like. Properly resource supported housing can save the health and social care economy pounds, thousands of pounds, hundreds of pounds. The most expensive forms of supported housing outside of hospital are still cheaper than keeping someone in hospital. I think Brian talked around about the differential of maybe 7 times over the course, 7 times the cost over a course of a month. And I think the final one is just a reflection of a challenge for both us and the wider sector, really. And other providers may feel they're in a different space to us around this, but certainly I think there is a sense, and it did flow through some of the conversations this morning, that we need to be able to better demonstrate the impacts and outcomes of our service delivery. So we've got some great case studies, some great individuals, but I think we need to have a better evidence base around what supported housing does and the impact that it has on people's lives, and the way it meets that unmet need, the way it can support a more efficient and more effective local health and social care economy. And I think that's a challenge to both to us as providers and indeed the wider sector as to how we understand the evidence base and how we gather, maybe in the first case, the right evidence base to be able to really make and support informed decision makings around these things. So I'll leave it there for now, and I think we've probably got around 7 minutes if anyone has any questions or comments they wish to make. Thanks.